All right, assalamu alaikum everybody. I hope I'm audible. So initially, I thought I'm going to give you like a full theory with pathology and immunology. And then we go through the MCQs and then we do the rapid revision points. But considering pathology is such a minor subject in your MRCEM Primary, I don't want you to waste a lot of time on it. So let's do something more fast-paced and a little bit of a shortcut. And so, yes, these notes are shared in the drive. You have access to them, but I had a feeling you're not going to study them or go through them as effectively. So we are quickly going to go through them so that you can go through them with me. There are 2 files, and we'll go through both of them and hopefully cover as much of this as we can today. Okay? Right, so let's start. Just to know how to use these notes, you will go through the clinical. Sorry, I think we got disconnected. Let's go back. So yeah, I was telling you about how we are going to cover this guide. So you're going to have a one-liner and then any related facts just to add something in case they, switch the MCQ or just add something different to it. Okay? All right. So like we covered this yesterday, so we are going to go a bit quicker. Okay? Types of necrosis. So let's cover the first thing, which is cellular pathology and necrosis. So this is the clinical stem you're going to get. A 62-year-old man presents 6 hours after crushing central chest pain. ECG shows ST elevation in V1 to V4. Post-mortem examination of the myocardium would most likely show which histological pattern. Okay, that's what the clinical stem looks like. So now we studied yesterday that myocardium specifically goes through a coagulative type of necrosis. Okay, so let's go down. Key facts: coagulative necrosis is the most common type. Myocardial infarction is the classic example. Cell outline is preserved. Architecture is maintained, occurs in all solid organs except the brain. Liquefactive necrosis is where brain infarctions and pyogenic, pus-forming or suppurative infections come in. There's complete liquefaction. Architecture is entirely lost. Brain has high lipid content and few structural protein. This is why it has a liquefactive necrosis pattern. Then you've got caseous necrosis, which is specific to TB and some fungi. So cottage cheese or cheesy macroscopic appearance. Histology-wise, it will show eosinophilic granular debris within your granulomas. Fat necrosis is acute pancreatitis, enzymatic lipolysis by lipase. You've got breast trauma, which is not related to enzyme, it's trauma related, and appears as a chalky white focus, calcium soot formation, sponification. So breast trauma can resemble breast cancer, but it's not. Fibrinoid necrosis, it's immune complex deposition in your vessel wall, commonly seen with malignant hypertension. SLE, vasculitis, eosinophilic deposits are seen in your smooth muscle wall on hematology staining. So gangrenous necrosis, this is where necrosis is present with putrefaction. You can have wet or dry, appears black due to iron sulfide formation. So this is just another table, a quick review. You can review this whenever you're going for the exam a day before, just to revise everything. Now let's cover the MCQ part. The brain is the only organ that undergoes liquefactive, not coagulative necrosis after infarction. So anywhere else in the body, infarction is going to cause coagulative necrosis, except for the brain. Okay, the brain, liquefactive. Got it? One liner to remember: coagulative MI, liquefactive brain abscess, caseous TB, fat pancreatitis, fibrinoid, SLE, or malignant hypertension. Right. Next one's apoptosis versus necrosis. So clinical stem, you want to look for 45-year-old woman with breast cancer commences chemotherapy. On pathological review, tumor cells show chromatin condensation, nuclear fragmentation, and membrane-bound cellular fragments with no inflammatory infiltrate. Which process is occurring? So all of these features are for apoptosis. Well done. So the feature you want to look for are the trigger. In apoptosis, it's a programmed physiological cell death. The cell shrinks in size, which is known as pycnosis. The membrane is intact. There's no inflammation, ATP dependent, so you have the cell driving this, and then chromatin condensed and marginated. In necrosis, it's a pathological injury. The cell swells up, membranes disrupted, there is inflammation, there's not a lot of energy required, it's just passive, and then you see karyolysis and karyohexis with the DNA material. MCQ poll to remember, apoptosis, so no inflammation and necrosis is present. If the stem says inflammatory infiltrate, it's necrosis. Caspases are the enzyme that execute apoptosis. These are inhibited by your BCL2, anti-apoptotic gene. You might want to remember this. One-liner, so apoptosis, tidy, silent, programmed cell death, there's no inflammation. Necrosis, messy, inflammatory, unplanned death. Very, very messy. Okay. Cell adaptation. Clinical stem, 55-year-old smoker, bronchial biopsy showing replacement of normal respiratory pseudostratified columnar epithelium with stratified squamous epithelium. Which adaptive process is demonstrated? Atrophy, so that is decrease in cell size and number, which the cause would be disuse, denervation, ischemia, and aging. This doesn't look like atrophy, does it? Then you've got hypertrophy. This is when there's increase in cell size only, okay? There's no division, just increase. And the examples are left ventricular hypertrophy in high blood pressure, hypertension, or your biceps in weightlifters, okay? Hyperplasia is when there's increase in number, okay? Examples are endometrial hyperplasia in estrogen excess. Then you've got metaplasia. This is when reversible change happens. So one adult cell type turns into another. This is what the clinical stem was referring to, isn't it? One cell type, which was normal respiratory pseudostratified columnar epithelium, turned into stratified squamous epithelium, right? So this is a reversible change. Just remember, metaplasia is reversible, okay? Examples are Barrett's esophagus, where your squamous epithelium turns into columnar. And the second example is bronchial squamous metaplasia in smokers, okay? Dysplasia is disordered growth. So dysplasia, disordered. This is usually pre-malignant. This can be reversible if you get rid of the stimulus, but you need to, require surveillance. MCQs. So Barrett's esophagus is metaplasia, not dysplasia. Got it? And what happens is your squamous epithelium turns into intestinal type columnar. Dysplasia comes later, and that is a risk of adenocarcinoma. NICE guidelines say surveillance with 2-yearly endoscopy for non-dysplastic Barrett's. Okay? So if it's not dysplasia yet, it's just metaplasia, you want to do 2-yearly endoscopy. One-liner to remember, metaplasia is reversible, dysplasia is pre-malignant, and anaplasia is malignant. Okay? Now let's talk about reversible and irreversible cell injury. Reversible cell injury is cell swelling, endoplasmic reticulum swelling, ribosomes detach, fatty change, and then cell can recover. Irreversible injuries include lysosomal rupture, nuclear breakdown, karyolysis, karyohexis, pycnosis, mitochondrial densities, and these are all just cell death inevitable. So anything that's either swelling up or detaching is reversible, but anything that's just breaking apart or rupturing is not reversible, okay? MCQ poll, the point of no return is cell injury. In cell injury is lysosomal rupture. Why? Because there's now release of enzymes that's just going to eat up the cell, autodigestion. Mitochondrial membrane permeability transition is another irreversibility marker. That's when your basically nuclear material is just broken down. One-liner to remember, lysosomal rupture equals irreversible cell injury. Cell death is imminent. Right, section 2, wound healing and bone repair. So wound healing, phases and cell types. So 35-year-old sustains a 4-centimeter laceration to the forearm. On day 4, what is the predominant cell type present in the wound? What type of collagen is being synthesized? Sorry. So day 4, right? Let's go through it. So hemostasis, that's the first thing, happens within minutes. How does it happen? Platelets come in, fibrin clot and vasoconstriction. Then you've got inflammation, which happens from like a few hours to about 3 days. You've got neutrophils coming in the first 24 to 48 hours, and then macrophages come in on day 3. Proliferation is day 3 to weeks. So on day 4, the predominant cell type would be macrophages. And then you've got fibroblast, angiogenesis, type 3 collagen coming in. And then remodeling. What type of collagen is being synthesized? A type 3 collagen, all right? Day 3 is macrophages, and then by day 4, you've got fibroblasts, angiogenesis happening, and type 3 collagen. So the most common, cell type would be on day 4, fibroblasts, new vessel formation, and then type 3 collagen happens first. And then remodeling happens over weeks and months and years, and type 1 collagen will replace type 3, myofibroblasts contract, and you've got scar tissue. Okay, so usually type 1 collagen, let's just discuss this now. So collagen types, type 3 is your early granulation tissue. Type 1 is mature scar or adult skin, and maximum strength, so 80% normal at 12 weeks. Myofibroblasts, these are responsible for wound contraction in secondary intention healing. Vitamin C deficiency, you want to remember, impairs your collagen synthesis. So tropocollagen hydroxylation leads to poor wound healing or scurvy. Then you've got cell regeneration or capacity. Labile cells like skin, gut mucosa generate best. You've got stable cells like liver and kidney, they're moderate. And then you've got permanent cells like neurons, cardiomyocytes. These heal by scarring only. Now let's talk about the MCQ part. So neutrophils will dominate day 1 to 2. Macrophages take over from day 3. They are the directors of healing, releasing growth factors like TGF-beta, PDGF, VEGF, all of these. Fibroblast arrives day 2 to 5. The sequence is a classic MCQ sequence, okay? One-liners, neutrophils first, then macrophages, then fibroblasts, and they lay down collagen 3, then it turns into collagen 1, and 80% strength at 12 weeks, okay? Now let's talk about primary and secondary intention. So primary intention, clean wound, opposed edges, surgical incision, there's minimal scarring. Secondary intention is wound not opposed, heals by granulation tissue from base upwards, more scarring. Granulation tissue is composed of new capillaries, angiogenesis, myofibroblasts, and type 3 collagen plus macrophages. The MCQ per you want to look for here is granulation tissue, capillaries and myofibroblasts, type 3 collagen. It is not pre-malignant. Do not confuse this with granulomatous inflammation, okay? Because that one contains epithelioid macrophages, which is seen in TB. Got it? One liner to remember, healing by secondary intention, granulation tissue. And granulation tissue equals new capillaries, myofibroblasts, and type 3 collagen. Now let's go to bone healing. So a 25-year-old rugby player fractures his radius. 6 months post-injury, the X-ray shows persistent fracture line with minimal callus. What is the definition of non-union, and which cells drive the remodeling phase? So let's see. Excuse me. Sorry. Hematoma formation. So that's day 1, right? You have a fracture, there's a hematoma forming, and then inflammatory cells come in. Inflammation and proliferation, that's in the coming weeks, so week 1 to 2. You've got periosteal response and vascular ingrowth. Then you've got soft callus, so fibrocartilage, which is week 2 to 3. Chondrocytes plus